So the common thing, anatomy, embryology is very important. Physiology of thyroid hormones, hyper and hypothyroid conditions, antithyroid drugs and the thyroxine pharmacology, indications for thyroid surgery, pre-op evaluation, intra-op management and problems, post problems and management, uncontrolled hyper hypothyroid patients coming for non-thyroid surgery. So why the name it's given? It's because it's like a shield. And the thyroid gland development, you correctly described how it is acting. I mean, coming from the pharyngeal pouch and coming down. And this is the anatomical location C5, C6, C7, and the middle lobe starting from thyroid cartilage going up to the fifth tracheal ring. And this is the lateral extension according to the vertebral level. And these are the ligaments, suspensory ligament of Berry and the pretracheal fascia, the reason for the gland moving during swallowing. Then they may ask you suddenly about the arterial blood supply and venous drainage, and also this triangle of Riddle's triangle where the recurrent laryngeal nerve is traversing and the chance of the nerve getting injured. This picture is seen in all textbooks about the formation, how the synthesis of thyroxine T3, T4 takes place, and what are all the steps in that, and how the release is controlled is by the feedback mechanism, and what are all the various levels at which it is done, and how you interpret the TFT, the thyroid function test. You always look at the TSH, whether it is normal, increased or decreased, and then based upon that, you look next at the T4. So these two should be correlating with each other. If they don't correlate, it may be secondary problem, not in the primary problem. And this is the structure. You have to remember this is the two benzene rings which are attached with an oxygen. And at the 3 and 5 level, you have to identify which is the structure of levothyroxine or T4. And if the iodine, the fifth position is removed from the outer ring, then it is called the active T3. Whereas if it is removed from the inner ring, then it is called the reverse T3, which is inactive. So this picture we have to remember. And mechanism of action of thyroxine and the thyroid hormone, it acts as the this is the G protein coupled receptor, and this is activating this and then releasing. The actions results in release of it also helps in synthesis as well as the release of the hormone from the gland. And this is the various mechanisms how it acts. It is a nuclear receptor activator. Thyroxine hormone T3 ultimately acts on the nuclear receptors to produce new proteins and then activates all these things: growth, temperature, oxygen consumption, beta adrenergic activity. So that is the basic physiology. These are the various functions which happen at the various systems: carbohydrate, nervous system, protein, lipid metabolism. So the BMR is the amount of energy or heat liberated by breakdown of food per unit time under standard conditions. And the patient should be a relaxed subject at comfortable temperature 12 hours after a meal, and the BMR corrected for age, sex and body surface. So this is the definition of basal metabolic rate, amount of energy or heat liberated by breakdown of food per unit time under standard conditions. And it is measured by heat produced by subject or oxygen consumption. The normal BMR for an adult male is 197 kilojoules per square meter per hour or 40 calories per square meter per hour. So these are all the various causes for both the hyper and hypo. Hyper, it can be overproduction of thyroid hormones like Graves or DSH, or leaking thyroid hormone due to thyroid destruction, or drugs, thyroid replacement drugs, drone or iodinated radiocontrast, and metastatic thyroid carcinoma. Hypothyroidism, it can be primary, secondary, or tertiary, and these are the various things. And you can see amiodarone can cause both hypo as well as hyperthyroidism. And biochemical findings in primary, of course, we all know about it. Thyrotoxicosis, it causes beta-adrenergic upregulation and sensitization to catecholamines. And there are the various conditions like Graves' disease, toxic multinodular goiter, adenoma, and thyrotoxicosis can also be caused by thyroiditis. Usually, hypothyroidism will be there in Hashimoto's, but hyper also can happen. And patients with thyrotoxicosis should be made biochemically and clinically euthyroid before any elective procedure. And risk of perioperative thyroid storm is usually higher following acute events such as surgery, trauma, or infection. And there is a condition called apathetic thyrotoxicosis. The cardinal features are apathy and depression in contrast to the excitability and hyperkinesis of hyperthyroidism. So it is not always necessary that a hyperthyroid patient should be more agitated, excited, or anxious. They can sometimes also have features of apathy and depression with a values which are higher. And this is the thyroid scan machine which you can find out. There is a condition called central hypothyroidism, which is often suspected in patients with hypothalamic or pituitary pathology. And they may have, even though they have hypothyroidism, where the TSH may be normal or low, or sometimes elevated as they do with a low free thyroxine. And this condition is diagnosed by free thyroxine index. So that free thyroxine index value is mainly for finding out central hypothyroidism. And these are the tests specific for thyroid function. And the interpretation of the results, this will help you to find out whether if it is hypothyroidism, you have to find both T3 and T4 will be low, T3 resin uptake will be low, free thyroxine index will be low, and radioactive iodine uptake also will be low, but TSH will be elevated in primary, but if it is secondary and tertiary, it will be low. Whereas hyperparathyroidism, these values are all elevated, but TSH will be low. There is another condition called T3 toxicosis, where there will be no change in T4, but T3 will be elevated, and no change in T3 resin uptake or T4 index, and TSH may be really low. So only T3 will be increased. That is why it is called T3 toxicosis. And there is another condition which is resembling hypothyroidism, which is called euthyroid 6 syndrome. It will be T4 will be low, T3 will be low, or sometimes no change in T4, only T3 will be low, but T3 uptake will be high, and TSH will be normal. So with a normal TSH, we find that T3 low and patient is in sepsis. This condition is more common in ICU patients. So sometimes they may get a patient like this, and that is called euthyroid syndrome. And thyroid neoplasia, sometimes they may ask you about the types of malignancies that you have. If they give you a case for total thyroidectomy, it may be papillary, follicular, medullary, or anaplastic carcinoma. Papillary is a good prognosis. 90% patients survive for 20 years after surgery. And classification of anti-thyroid drugs, drugs which inhibit hormone synthesis like carbamazole, metamizole, or propyltyrosol, inhibition of hormone release by iodine, iodide, and organic acid, and radioactive iodine to abolish or kill all the follicle cells so that the secretion is decreased. And ionic inhibitors are thiocyanate, perchlorate, nitrates, which are all not used commonly nowadays. And the comparison between propyltyrosol and carbamazole. So this is less potent, whereas carbamazole is more potent. And the more important thing is it is more the complications are more because of the agranulocytosis that is produced. So they almost become obsolete, and this is the drug of choice for treating hyperthyroidism. And iodine salts and Lugol's iodine is another common question they may ask you. Lugol's iodine is nothing but 5% iodine in 10% potassium iodide, and 5 to 10 drops per day is given, especially before surgery to reduce the vascularity of the gland. And when you stop it, you must operate within 5 to 7 days. It's called the window period. And after that, if you under this iodinated contrast media, hypodate, it suppresses conversion of T4 to T3 via the 5-deiodinase in the liver, kidney, and peripheral tissues. This is very useful in rapidly reducing T3. So, in cases where an uncontrolled hyperthyroid patient is coming for an emergency surgery, this hypodate has proved to be useful in reducing the incidence of thyroid storm also. Please find out what is the dose and the route of administration. I'm not sure about it, but this has been given. And they may ask you about this Wolff-Chaikoff effect. That is, when you give iodine, it turns off the thyroid. So remember that. So this Lugol's iodine suppressing the iodine production is what is called as the Wolff-Chaikoff effect, as a feedback mechanism. And radioactive iodine is used for destroying the gland in resistant hyperthyroid patients. And beta blocker, it also controls the cardiovascular effects, nervousness, tremor, as well as peripheral conversion of T4 to T3. And two important biological functions of thyroid hormones are normal for needed for human growth and development, especially the CNS. In adults, it maintains metabolic homeostasis and affect all organ system. And for hypothyroid patient, this is the replacement. L-troxin, levothyroxine is given. We have not discussed about hypothyroid. So remember, this is the substitute that is available in micrograms of 25, 50, and 100. And indications for thyroid surgery: malignancy, obstructive symptoms, retrosternal extension, hyperthyroidism unresponsive to medical therapy, or recurrent hyperthyroidism, cosmetic or anxiety-induced Hashimoto's disease, hypothyroid goiter with superimposed lymphoma, are all the indications. Now, this is the equipment that you need for auscultating over the gland to assess the deglutition movement, knee jerk to find out the status of musculoskeletal system, and you have to go for an anterior and lateral approach, as well as to see the hands of the patient. These are all the changes that you may see: dry skin in hypothyroid, and sweating with the warm, more moist skin in the hyperthyroid patient. And the phalanges are grown over. It is called thyroid arthropathy. So that happens in Graves' disease, and palmar erythema may be common, and peripheral tremors are maybe there, and pulse, usually tachycardia, hypothyroidism, there may be bradycardia, and the rhythm may be irregular because of atrial fibrillation in thyrotoxicosis. This is the pretibial myxedema, and these are all the eye signs that she described. And clinical examination, this is the test you do for finding out the deviation. So if you are able to insinuate your finger between the sternocleidomastoid and the gland, and you are not, if it goes in freely, that means the trachea is in the midline. And this is the posterior way to palpate. This is observing the deglutition. This is the tongue protrusion. This is the percussion over the manubrium sternae, and this is the auscultation over the gland. So sometimes ward rounds, if they ask you to demonstrate how you will examine the gland, then all these points may be useful. Investigations: serum calcium is very important in these patients, because especially if we are going to do a total thyroidectomy, then preoperative calcium will be important to find out whether the patient develops hypoparathyroidism and low calcium postoperatively. And so this is just an X-ray to show how a compression can happen This is the normal tracheal air shadow. Then retrosternal goiter producing the compression deviation of the air shadow. And this is the retrosternal gland producing the enlargement of the upper mediastinum. And the technique of anesthesia for this is GA with ET tube, position supine with extension, eye protection is important, IV line placement for easy access, monitor location at the foot end, pressure points to be protected, choice of ET tube will be a flexometallic or a North Pole orally, control is a spontaneous. Spontaneous is very rare, majority we go for control ventilation. This is the flexometallic tube. This is the North Pole or nasal ray tube. Nowadays, to monitor the recurrent laryngeal nerve, we have electromyographic attached tube mounted on the trachea. So these tubes are used nowadays to intraoperatively test the integrity of the vocal cords. And this is the position. This is how you protect the eye from the effect of compression of the breathing circuit. And this is the headrest that is used to place the head. And with the hemodynamic response of coughing and straining extubation, you can do either a deep extubation in uncomplicated airway, or you can do Bailey maneuver, where you can introduce an LMA behind the tube and then deflate and remove the endotracheal tube and ventilate the patient with the LMA, which is called Bailey maneuver. And then laryngotracheal anesthesia with topical lidocaine, or you can inject alkalinized lidocaine into the cuff for short procedures, or you can give dexmedetomidine 0.5 microgram before extubation, low dose remifentanil. And the regional techniques, sometimes they may ask you, can you do a small right or left lobe nodule excision under any regional? Then the ideal technique is cervical plexus block. You have to give both superficial and the deep cervical plexus block, or you can give a cervical epidural also, as you see in this picture. Then thyroid crisis, hemorrhage, air embolism, the need for sternotomy if retrosternal goiter are the common drop complications. The newer challenges are intraoperative neuromonitoring of recurrent laryngeal nerve, which is called INOM, and endoscopic thyroidectomy, which is becoming more and more popular, and robotic thyroidectomy also is being done nowadays. So these are the various ports that are applied through the endoscopic. Various approaches are there. Transoral approach. This is the transoral. This is also called natural orifice approach, because we go without creating a breach in the skin. We are going through the normal orifice. So this is called normal orifice approach. These are all the various port approaches. Airway complications, immediate or recurrent laryngeal nerve injury, tracheomalacia, laryngeal edema. Intermediate complications, hematoma. Late complication is hypocalcemia. So they may ask you about the various types of recurrent laryngeal injury. The most dangerous is the partial bilateral injury, which will cause a complete adduction. Okay? So that is what you have to read about. And this tracheomalacia, this is the normal view. This is the tracheomalacia view. So if you have a fiber optic and see, this is, you can see the collapse, and that is the. So you always do a cuff leak test to rule out both tracheomalacia as well as laryngeal edema. So if you hear a nice leak sound, then you can safely extubate. And you must also have measure the exhale tidal volume. In cases of edema or collapse, the exhale tidal volume also will be reduced. So you will be finding, you can detect that before extubation. And this is the post-thyroid surgery monitoring that is recommended in the British Society, and they call it as DSATS, difficulty in swallowing. In the early warning signs and the new early warning signs, swelling, anxiety of the patient will be tachypneic or stridor will be there. So once you find that, oxygenate, give 15 liters of oxygen per minute. Nurse the patient at 45-degree head up. Management for suspected hematomic following thyroid surgery. You evaluate, and then this is the algorithm that has been described. Management of suspected hematoma following thyroid surgery. Oxygenate and evaluate. And then, are there any signs of airway compromise? Yes, then immediately call for help. Evacuate the hematoma. See whether there is a clinical improvement. If it is yes, just observe, supplement oxygen. No, then go for intubation. And if you are successfully able to intubate, observe. No, then you have to go for emergency front of neck access. So these are all and you can use, considering using video laryngoscope, and limit the attempts to 3+1. Okay? So all these guidelines are there in the British, Anesthesia Journal 2021. And after total thyroidectomy, the common hypocalcemia is because of the PTH, that is parathormone level have to be measured, and then the treatment or correction of calcium. If the calcium level is more than 8 milligram, the patient symptoms, just continue with the regimen that is started post-op. If it is between 7 and 7.9, patient asymptomatic, just observe mild symptoms, give extra dose of oral calcium, 1000 milligram. But if in severe symptoms, you have to give 2 grams of IV calcium gluconate in normal saline for over 1 hour. And then start calcitrol, 0.5 milligram, and increase frequency of post-op calcium, and replace magnesium also if low. So another electrolyte that you have to constantly monitor in patients with calcium is also magnesium. And so the standard dose is 2 grams IV. And so this is the recommended content of thyroid surgery. Again, this slide should have come earlier. So this is the SCOOP acronym. Skin exposure, cut the sutures, open the skin, open muscles, and pack the wound. So step 1 is contact crash team and duty surgeon, cut the subcuticular sutures, open the skin to expose the strap muscles, and then push the finger, expose this, remove the clot, then pack the wound. So these are all the gadgets that should be present in the, just like the difficult airway card, there should be the recommended things that should be kept in the hematoma evacuation. So that completes all the newer things also included in the management of these cases. Any doubts?